All right, here we go. So this is going to be the start of week 3, lecture 1 of our summer semester, pharmacology 2023. We left off, we were talking about DNA disruptors. I believe we finished the fluoroquinolones and we were going to jump into Bactrim. So let's jump into it. Yep, I can see it right there, Bactrim. So let's share. Minimize me, right? You don't want to look at me. You got to hear me. You don't got to see me though, right? And there it is. Yeah, Bactrim. Okay, let's just make sure. Make sure. Okay, yeah. Fluoroquinolone. So DNA disruptors. So we talked about topoisomerase 2 and 4, DNA gyrase, etc. So Bactrim, a drug you're going to use quite often. I'm going to go ahead and give you some pearls now. Bactrim maintains pretty good activity against methicillin-resistant Staph aureus. It's going to be, in most cases, especially community-acquired, you're going to see sensitivities around 90% or higher. But one thing I want you to appreciate is you don't have the best overall streptococcal coverage in terms of group A strep or what is the typical pathogen for erysipelas. So that's why, and people argue with me sometimes, but that's why I think if you don't know you have a strep or a staph infection for a skin structure infection, doxycycline is a nice choice because you do get very good Streptococcus pyogenes coverage, but you also get methicillin-resistant Staph aureus coverage. Now remember, when you have an abscess, usually if you have a skin structure infection that does not have purulence, that's going to be more along the group A strep. If you have purulence, most of the time that's going to be a staphylococcal infection, whether it be methicillin resistant or not. So just something to keep in mind. And then we'll also talk about dapsone. But when you talk about Bactrim, sulfamethoxazole trimethoprim, this is the sulfa drug, if you will. And I want to give one more pearl. So when you do have clinical failures, number one, if we're talking skin structure infections, and that's where we use this, a large proportion of the time, it's deployed to treat abscesses, if you will. Number one, source control, right? Get the source control. Let's check that. Two, though, another thing, when Staph aureus interacts with human DNA, it makes a synthetase type enzyme that actually destroys the Bactrim. But this doesn't occur in a petri dish because there's no DNA there. So it's not an in vitro phenomenon. So I think it is DNA synthetase is actually the name of the enzyme. But in your culture and sensitivity, you'll get sensitive. But then you get a therapeutic failure. Well, in vivo, when you can have that DNA synthetase that renders the Bactrim ineffective, that's when you don't get the killing effect. In a petri dish, it's there. That's in vitro. There's no DNA to interact. So a lot of times that has to do with an inoculum effect and something you need to appreciate. So anyway, the spectrum of activity, certainly methicillin-resistant Staph aureus. You do get some gram-negative organism coverage. A big one certainly is going to be E. coli. You see this deployed a lot of times for urinary tract infections. It is considered the drug of choice for Stenotrophomonas multifida. You always hear me say minnow for steno, minocycline. That's typically when you have some resistance to Bactrim. So it is considered the drug of choice for Stenotrophomonas multifida, but it's also the drug of choice for Pneumocystis jiroveckia. Used to be Pneumocystis carinii. It's a fungus that you'll see with usually with patients who have human immunodeficiency virus with CD4 counts less than 200. So by definition, they have acquired immune deficiency syndrome or AIDS, and we'll use it for that prophylactically or to treat it. It can also be used for Legionella pneumophila, so that's something to keep in mind. But you don't get enterococcal coverage. You don't get your pseudomonal coverage. There is no bacteroidal coverage nor atypicals. And there's my discussion right there, plus or minus streptococcus coverage. I'm not using this for group B, group A strep, nor am I using this for pneumococcal infection, just streptococcus pneumonia. If I feel I have an erysipelas and I have a group A strep infection of the skin, I'm going with cefazolin or I'm going with amoxicillin. So what types of infections do we use? Do we use a sulfa drug? And again, I told you it is the drug of choice for pneumocystis jiroveckia. Sometimes you may see that as PCP or pneumocystis carinii pneumonia. And then, of course, Stenotrophomonas multifilium. The dapsone will deploy for the treatment of leprosy. We don't see dapsone as much. It has some immunosuppressive side effects. Not that the Bactrim's much cleaner sometimes, especially when you think of number one, the trimethoprim component. One thing you need to appreciate is trimethoprim will cause potassium retention. So a patient who has kidney injury, chronic kidney disease, or acute kidney injury, you need to see what their potassium is before you deploy it. I'm going to give you a study. There was a study. It was cefazolin versus Bactrim. There was no on skin structure infections. There was really no change in outcomes, but there was an increase in mortality in the Bactrim group. And the reason for that was due to increased potassium, specifically to the point of life-threatening hyperkalemia. So you need to appreciate the fact that the trimethoprim component is going to cause, similar to the way potassium-sparing diuretics will cause potassium retention, you see the same with Bactrim. So keep that in mind. But here's your coverage. Good coverage, very dependable for MS MRSA. Just know you do need to have source control, because with that high inoculum, you're going to have that DNA synthetase activity in vivo. You're not going to have it in vitro. And again, it may say, well, it showed sensitive. Why did I have a therapeutic failure? Number one, you didn't have source control. Or number two, in vivo activity, you were having a destruction of the drug. We don't really deploy it as much for H. flu or Enterobacter, but no doubt for UTIs with all these bugs. I'm sure when you may have taken it for a urinary tract infection. It can be complicated or uncomplicated. The big thing is for how long do you treat it? Is it 3, 5, 7, depending on, is it a simple cystitis? Is it a complicated UTI? Is with the upper genital urinary? Is it affecting the kidney, more of a pyelonephritis? Now remember, those patients are going to typically have some fever. They're going to have some leukocytosis, and more importantly, if you do that Murphy's punch of that costovertebral angle, you're going to have some pain. You're going to see some withdrawal, and the patient will complain about that. So how do these work? There's two mechanisms that are ongoing. You have your sulfamethoxazole and you have your trimethoprim. So the sulfamethoxazole mimics PABA, and this is in inhibition of the dihydroperturate synthetase, and you can see it working right there. And in essence, the dihydrofolic acid, and that's a bacterial static perspective, is being broken down. And then with the trimethoprim, just go another level. Instead, you're going to the dihydrofolate reductase, and you get the point, DNA disruption. But the compounds, you have to have both to get that benefit you're looking for. And when you hear the word tetrahydrofolic acid, that's actually the active form of folic acid. So sometimes you'll hear that these are folic acid inhibitors in and of themselves. But remember, as humans, we're going to get our folic acid from the environment. Bacteria, they have to synthesize their own. So we're actually interfering with that synthesis, and without that, they can't get purine analogs. They can't get dioxin or DNA. So there you go. Very simple, right? But it's a two-drug combo that are given together. Bacterial static. Remember, though, don't let static and cidal drive which drug you're going to use or not. Excellent oral absorption. This makes it a nice drug to give orally, especially if you're doing an IV in the hospital. So something to keep in mind. It is distributed to the placental barrier, I should say, through or across the placenta and into the breast milk as well. Primarily metabolized through the liver. So if someone is a child use C or D, you may want to risk benefit, use with caution, but it is eliminated in the kidneys. And so it does require renal dose adjustments. Now, if there's ever a drug interaction that you needed to know, it's Bactrim and warfarin. And it's not as profound now in terms of seeing it because we have the DOACs, the direct oral anticoagulant drugs. So it's not as common because we don't have as much warfarin. But if you give a patient on warfarin Bactrim, never know. If the pharmacist doesn't call you, shame on them. If you actually do that, shame on you. you're going to have your INR increase substantially. It's major no-no. So that's a drug interaction you need to be aware of. Same can be said with phenytoin and methotrexate. A lot of times your methotrexate, you'll see with rheumatic type inflammatory conditions, not chemotherapy, where we do high dose and we do methotrexate rescues, but this is also a pholinic type drug. And you can really cause a lot of harm with methotrexate. When it gets toxic, it can lead to death. Remember, again, in the chemotherapy world, we have what we call a methotrexate rescue. We give a high dose to kill the cancer, but it also kill the patient. We actually, 24 hours later, we draw levels and we have to give folinic acid, a product called leucovorin, to do a methotrexate rescue. So it's something you need to appreciate, but these are very important drug interactions that you need to know. Sometimes we just, yeah, this may happen, but clinically it's not a problem. These are ones that clinically they're a problem, and you need to know them and appreciate them. Common side effects, you can take it with food, but nausea sometimes can be a big one. We talked about the hyperkalemia potential. You're going to see this with higher doses in patients who have either acute kidney injury or, more important, chronic kidney disease. Now, also appreciate that if someone had chronic kidney disease or they don't and they're borderline and they're on spironolactone and or an ACE inhibitor or an ARB, you need to be appreciative of the fact that the sulfur is going to raise your potassium. It can be anywhere from a half point to a whole point. So please appreciate that. With all your sulfur drugs, and we talked about, I made a little comment about dapsone, but you can get hematological disturbances in the form of some of your megaloblastic anemia, certainly leukopenia and thrombocytopenias. The big one for me that I've seen it before in a couple of patients, is the rashes, specifically toxic dermal necrolysis and TENS or Stevens-Johnson syndrome. As I told you all, I've witnessed this 5 times in my career. The culprits were phenytoin, Bactrim, and allopurinol, just those 3 drugs. You can also get crystallurea, and you can get some connectors. Some of the clinical pearls, we don't use it in children that are less than 2, and for obvious reasons. And then pregnant women and patients need to be hydrated. Why? You see that side effect, crystallurea. So please, 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 please hydrate. When I think of 2 drugs that need good hydration, I think of allopurinol, and I think of Bactrim, and I think of acyclovir as 3 drugs that come to mind. But patients need to be hydrated, so make sure that they're drinking plenty of water. And then, of course, patients who do have a G6PD deficiency, you would want to avoid juice because you would have a risk of having hemolytic anemia. So please keep that in mind. And so leaving Bactrim, moving on to metronidazole. This is a drug we use predominantly for anaerobes. We do use it for protozoa. Used to be a drug of choice for Clostridium, now referred to as Clostridoides, but let's talk about it. So metronidazole, it comes in IV or PO. That makes it very nice for transition from the hospital. And topical, usually when it's topical, it may be for acne or sometimes for vaginal disorders. But its spectrum of activity, it has anaerobic, gram-negative activity. That's what we use it for. And more specifically, Bacteroides. So Bacteroides fragilis. So it's a good option if you want to have more narrow spectrum coverage. You can use it. Let's say you have E. coli that's pan sensitive. You could use it with a cefazolin or a ceftriaxone and not necessarily have to use your more broad spectrum antibiotics, such as azocin or meropenem, and maybe preserve some of the normal flora, the microbiota of the gut, and have less risk of getting a Clostridium difficile infection. So don't be afraid to give it with another drug to avoid like zocin or meropenem, drugs along those lines that are far more broad spectrum. Now, from a gram-negative perspective, we mentioned the Bacteroides. I'm going to call it a drug of choice for Bacteroides. There's plenty. But when you look at culture and sensitivities and you look at antibiograms, for the most part, it's still 100%. It's still 100%. It's a great option. I can't say the same for some of the other combination products or drugs that cover Bacteroides. The anaerobic gram-positives, so does it cover Clostridioides or Clostridium? It does. But remember, we're seeing more resistance. And when we talk about the treatment of C. diff, you know there are 2 drugs of choice. It's vanco or fidaxomicin, oral vanco. or fidaxomicin. The brand name is Difficid. If you do vanco first and you have a therapeutic failure, then you go to Difficid. If you do Difficid first and you have a therapeutic failure, then you go to vanco. Now, could you use metronidazole for C. diff infection? Well, number one, two things to keep in mind. If the patient is MPO and they have toxic megacolon, you can give it IV. So for all practical purposes, if you can't access the enteral route, you can use vancomycin enemas from the bottom, and then you can give metronidazole IV to the top. But for the most part, it's no longer considered a drug of choice. Now, if a patient can't afford oral vanco or oral Difficid, the fidaxomicin, yeah, give the vancomycin a shot. So what do we use it for? For the most part, the oral or IV, they're used for intra-abdominal infections, specifically to cover those Bacteroides species. That's it. Also, bacterial vaginosis, we can use it for trichomonas. And then there's your C. difficile. Remember now, this has a new taxon. It's Clostridioides difficile. But remember what I just said, it's no longer the drug of choice. It doesn't mean it can't be used, but we're going to go with vanco or Difficid first. Then from a topical perspective, again, it can be intravaginally for vaginosis, also rosacea and trichomonas. That can be topical. There's a topical metronidazole, so something to keep in mind. But how does it work? You can see the structure. It diffuses into bacterium, protozoa, and that nitro group, and you can see it there. I'm going to call it more of a nitroso group. And its structure has to be reduced, which means it has to receive an electron. You remember that from general chemistry. To be activated. Well, guess who's going to donate that electron? Those anaerobes are. They have the ability to donate it. Aerobes don't. That's why it doesn't cover aerobes. So guess what? Once that nitro group is reduced and forms that free radical, we have disruption of the DNA. And there you go, cell death. And this is bacterial syndrome. Okay. Okay, what does it cover? Boom, there you go. That's what you need to remember right there. For the most part, that's it. Simple as that. So highly bioavailability when you give orally. So if you have a patient that's on oral metronidazole, or IV metronidazole, don't be afraid to do an IV to PO adjustment and get them maybe home sooner. If you're keeping around just for IV, this is a good drug. Very high volume of distribution, distributes nicely throughout the body. It is hepatically metabolized. If you remember from the first semester, we used an example of hepatic dose adjustments, and the example I actually used was metronidazole. Now, it's hard to put like renal function, we can calculate an estimated creatinine clearance or an estimated GFR, or we can even measure it, know the truth, but we can't appreciate that with hepatic failure, so you can do your Child-Pugh scoring. So I guess when you get beyond an A, B, if you're calculating a C or D, that's when you'd want to dose adjust your metronidazole. But there is no, it does have renal excretion, but there is no renal dose adjustment to recommend. Now I'm going to, so here, the disulfiram-like reaction, this is what we're taught in pharmacy school. This is a medical myth. So if you're not familiar with disulfiram, they'll give disulfiram. They'll have alcoholics in clinics. They'll have them drink alcohol. They used to do this. You would drink copious amounts of alcohol, then they would give you disulfiram, and you would just puke, 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 and puke. And it was almost like a negative response to create a positive behavior. I'm going to avoid alcohol. And then when you're done, and they would give you disulfiram to take to be a deterrent from drinking alcohol. It's a true story. It will make you have, very, very severe pronounced vomiting. But so they thought with metronidazole you have the same thing, but I'm going to tell you that's a medical myth. It breaks a lot of people's heart. The potential's there, but there is not a disulfiram-like reaction when taken with alcohol. And it says avoid for at least 3 days after treatment completed. This is what we were taught in school. This is probably what people are going to tell you, but I'm going to go ahead and tell you, say it's a medical myth. And if someone challenges you, look it up and say, well, it's not a true reaction. It does go through the cytochrome P450 system, so please appreciate the potential reaction or interaction with warfarin. But this is the one that's always fun to talk about. And now, if you're on the pants, and this is a test question, just go ahead and amuse the test writers and say, yeah, okay, there could be a potential for a disulfiram reaction, but I just want you all to know when you get out in clinical practice what the real story is. That's the scuttlebutt, and we're going to stick with that medical myth. So common reactions, this is the nausea and vomit. This is the problem with oral, though, is the potential for nausea and vomiting, just in general with it. But I will tell you, and this is legit, you will have a metallic taste, and people will know about it. Potential to have a furry tongue, and then with prolonged use, you can certainly have peripheral neuropathies. Now, there is a black box warning talking about if you take it long term, having a carcinogenic effect. But I consider metronidazole a very, very vital part of our weapons to treat specifically bacteroides. It's maintaining sensitivity, so I'm not too concerned about these. Now, the clinical pearl, remember, based on those 2018 IDSA guidelines specific to C. diff, metronidazole is no longer a first-line therapy. And when compared to PO vancomycin, patients using this therapy had lower clinical cure rates and higher rates of recurrence. Now, if a patient can't afford oral vanco or the oral fidaxomicin, which is going to be in the tune of $4,000 to $5,000 for 10 days of therapy, it is okay to use metronidazole, but just know you're going to have a higher risk of failure. If the patient can take oral vanco, can afford it, I should say, start with that first, but it's become relatively affordable compared to what it was, but Difficid is still insanely expensive. Okay, nitrofurantoin, this is a big one. This is a drug that I think you'll see deployed often in your practice to treat specifically cystitis. You don't want to treat anything that's a pyelonephritis, but it has excellent spectrum of activity. It's going to cover those aerobic gram positives, including your enterococcus, and more specifically those Staphylococcus cyclophyticus. If you remember, when we talked about the species in the genus Staph, Saprophyticus is related to urinary tract infections in females with having sexual relationships. And so you can actually use it prophylactically or preemptively after vaginal intercourse. So you do also get aerobic coverage of many gram-negative organisms, including some of your ESBLs. You certainly don't get your methicillin-resistant Staph aureus. Now, I'm going to tell you right now, if you see MRSA in the urine, now remember, when we think about urinary tract infections, that's more of an ascending phenomenon. And so when you look at, there's the rectum, and specifically with females, and you talk about the anatomy, it's more, you have the end of the ureter there, the urethra. You can see here between a lot of the E. coli and other things that can infect a woman or a man, but women more likely. You can see just from the anatomical or the anatomy of a female versus a male, you're at a higher risk. So colonization can occur just from, it can be from stool or whatever, because the rectum versus the proximity to the urethra. I'm trying to explain it without being gross. But my point being is it's ascending, meaning if we look at it sideways, there's your urethra and there's your bladder, there's your cystitis. It's going up this way. When you have, to get back to my point I'm trying to make, I didn't mean to go into a whole anatomy and physiology spill of the female, but methicillin resistant or any Staph aureus, whether it's MRSA or MSSA, if you're growing that in the urine, so you get a urine sample, this is the bladder, and you're growing MRSA. MRSA tends to be a descending, means it came from somewhere else, specifically the blood. So if someone's sick and they're growing Staph aureus in their urine, it behooves you to get a blood culture just to make sure. A good 30% of those, if I'm quoting literature right, that it's a disseminated disease from the blood. Now, the reason they call it descending is it goes from the blood to the bladder. But when you have your gram-negative infections, those are the ones that are ascending because they go up. And those are the ones that the patient has a UTI and they have a fever and systemic symptoms, and you get a blood culture and it's growing E. coli. Same sensitivity pattern. That's disseminated disease from the bladder or the urine to the blood. But MRSA is just the opposite. So please appreciate that. Anyway, back to the coverage of nitrofurantoin. We're only going to use this for lower UTI infections, specifically cystitis. We're not using these for upper urinary tract infections or pyelonephritis, but you're not going to get pseudomonal coverage. You're not going to get anaerobic coverage, and atypicals aren't really going to be a problem in the urine, but you're not going to cover that. Certainly Pseudomonas can, not Bacteroides for the most part. But where do we use it? Only lower urinary tract infections. So please, please, please appreciate that. If someone's having pyelonephritis or signs and symptoms that go beyond that, systemic signs and symptoms, especially associated with fever, you don't want to use nitrofurantoin. It's just not what you want to do. How does it work? You have a nitric oxide group, but it's static right there, but it's enzymatically reduces that nitric oxide group to active agent, and that's what inhibits the bacterial enzyme. Again, these are DNA synthesis disruptors, so it disrupts the DNA. That's what's going on with nitrofurantoin. Now, good oral absorption, food will increase the absorption. So if I'm doing patient counseling, I always have them take it with food. And a lot of drugs, food may slow the rate of absorption, but it doesn't change the overall area in the curve or the overall exposure. But this is one where you can increase your exposure by taking it with food. So I always recommend it, take it with food. Now, this is very important. The second point does not achieve therapeutic concentrations in the upper urinary tract. So we do not use it for pyelonephritis. This is going to be for those just acute, simple cystitis, uncomplicated. You have the patient, male or female, that complains of dysuria. They're going to the bathroom multiple times, urgency, more frequency, pain upon urine, smell. That doesn't happen. Urine, a lot of things. You can eat certain foods and change your smell of the urine, but you know the signs and symptoms of a UTI. The patient's actually symptomatic, but they're not showing systemic signs of an infection, or they're not showing like a fever or leukocytosis. They don't have CVA tenderness. They don't have all that would make you think it's something more sinister, like an upper pyelonephritis, if you will. Another pearl, it's renally eliminated, and to get the concentrations you want, it will not work if your creatinine clearance is too low. And how's too low? We define that as 30 mils per minute. Some will tell you less than 60. Some will tell you less than 40. I go with the less than 30. So it's up to you. If you want to go to an alternative because you don't like someone's renal function, that's up to you. But this is the number, less than 30, that I go with. New literature, not new literature, but changes from when I was taught support to all the way down to a creatinine clearance of 30. From a drug interaction perspective, it's a clean drug. No major ones to speak of. Adverse effects, the common would be potential for GI disturbances, but you're going to take that with food. So you're going to try to mitigate that. The next one, it's going to be hard to do when you're going to get the risk of pneumonitis or specifically fibrosis. It's going to be with longer treatment courses. And many times this is going to be even using it for preemptive or prophylaxis or preventative UTI. Sometimes you'll see it. You can get peripheral neuropathy. You can get hepatic dysfunction. So nitrofurantoin, it is a very safe drug. It's a drug with high utility, very good drug to use, but please appreciate your length of therapy. If it says treat your symptoms, I think for nitrofurantoin, for simple cystitis, it's now 5 days. It used to be 7, it used to be 4. Again, those Constantine units. Let's do it for 2 Constantine units. Well, Constantine units a week, 7 days. So let's do it for 2. That sounds good to me. Here. Bunch of fat men with gray hair saying, let's do it. But I do want you to appreciate all these potentials when you prescribe it. But guess what? You all are going to be good stewards of your antibiotics, and you're not going to extend more than, it may even be 3 days. Each one's different. I know the fluoroquinolones, which you would not want to use for simple cystitis, I think are just 3 days. I think nitrofurantoin may be 5 days. You certainly don't need to go beyond that. Some clinical pearls, again, remember what I told you, it won't work if you have pyelonephritis. So if you're suspecting that, you don't need to use that. We talked about the creatinine clearance less than 30. So if a patient has poor kidney function, don't use it. Do not use in pregnant women at term, can cause hemolytic anemia in the infant. When you're on your women's health rotation, I want you to ask your OBGYN, because you read this warning, do not use in pregnant patients at term. And if you have a test question, I want you to do that. But it is used all the time in the 3rd trimester in pregnant women. So ask your OBGYN preceptor when you're doing women's health, ask them their opinion of that, because even though it says not to do that, I see it in the third trimester all the time. I think this may be something at term. So anyway, you do see it used. But again, I've told you my thought on pregnant women and medications in general. Talk to your OBGYN. That's their gig. That's their thing. They know exactly what you can and you can't take, and they're not going to prescribe something that's going to be detrimental to you. Something that's commonly used is nitrofurantoin. And then again, with the like the Bactrim, we talked about the G6PD deficiency and the risk of hemolytic anemia as well. If a patient had such a deficiency, you'd want to avoid. Okay, and here's our fidaxomicin. Again, this is only used for Clostridium. Remember, this is Clostridioides now. Difficile, it's narrow spectrum. It plays kind of like a macrolide antibiotic, but it's not absorbed. It is considered a first-line option for C. diff. So is vancomycin. If you give vancomycin and that you have a relapse, you give fidaxomicin. If you give fidaxomicin and you have a relapse, you give vancomycin. This is expensive. You're looking at $4,000 to $5,000 probably to treat a patient with fidaxomicin. But the brand name is Difficid. It is similar to macrolides, very narrow spectrum, specific for C. diff. It's not absorbed, it's topical, but it acts on RNA polymerase, and that's what causes, when again, as you know, you get back, you block transcription. So transfer RNA, messenger RNA disruption. The end game is protein synthesis, termination, and cell death, and it is bactericidal. So keep that in mind when you think of fidaxomicin. Adverse effects, minimal, right? It stays in the GI tract where you want it, so there is no dose adjustments regardless of renal, hepatic. There's no drug interactions. Common adverse effects, I don't even know if they're common. I've never heard anybody really complain of adverse effects, but nausea, vomiting, abdominal pain. I think this is probably more likely to be related to your underlying pathology, your C. diff infection, and not necessarily the drug. And the hematological disturbances, again, when you see these, if a drug's not absorbed, how can it really appreciable have an effect on your bone marrow? But clinical pearls, it's pricey. Before you order it, you need to make sure the patient can afford it. And then I told you it's similar to a macrolide. So if there is a potential for cross-reactivity, if a patient has an allergy to macrolides. And if I ask you the question, name the macrolide antibiotics, what would you say? Throw the azolides in there. Not going to answer it for you, but I hope you're able to rattle that off. Okay, the rifamycin's not going to go into a lot of detail with these. These are accessory antibiotics. For the most part, we never give them by themselves for systemic use. The rifampin's going to be the prototypical drug. And when you think of rifampin, I'm hoping you think of one of a 4 cocktail of Mycobacterium species, specifically Mycobacterium tuberculosis. This is given for the whole kit and caboodle of the however long the regimen is. Rifampin, though, is a drug we don't give by itself because it induces its own resistance very quickly. So the spectrum of activity, though, we will give it sometimes in combination for staphylococcal infections, including MRSA. What we like about it is rifampin can actually penetrate biofilms, and that makes it an attractive alternative in combination therapy with vancomycin for, let's say, a prosthetic joint infection. Usually we'll do 600 milligrams once daily. Now, the question is, should you break it up into divided doses? The stuff I've read shows you get a little bit better outcome if you do one big dose per day, but you might see 300 twice daily. You may see 600 daily. It just depends on the provider. But anyway, that's going to be the big place you see it, is in combination to penetrate biofilms or prevent biofilm formation on those prosthetic joints specifically. The other ones can be the rifabutin and rifapentine. These can be substituted for rifampin depending on, do you want drug interactions, do you not? But anyway, you're going to also get your MRSA coverage. You also get those mycobacteria, specifically tuberculosis. And we also use it, though, by itself for meningitis prophylaxis. I believe we give it over 48 hours. And by itself, that's okay. You also get Salmonella and Campylobacter coverage, but we would not use it for that. You're certainly not going to get Pseudomonas enterococcal or any anaerobic coverage. So what do we use these for preferentially? Mycobacterium tuberculosis. It can be deployed in avian complex as well, but you're looking at TB, tuberculosis. Rifampin for your staph infections. Remember, we can also give it prophylaxis for patients exposed to Haemophilus influenza or Neisseria meningitis. And then the rifaximin, traveler's diarrhea. Where you see the rifaximin the most is for hepatic encephalopathy. It works very well compared to lactulose. The reason lactulose, we titrate that to the number of bowel movements, and it's not tolerable, and patients will stop taking it. Their ammonia levels will creep back up when they get an associated hepatic encephalopathy. So we'll give this, and it's more palatable, but it's more expensive. That's the problem. But it is very effective for hepatic encephalopathy. It works very well. And then how does it work? Again, RNA polymerase inhibition, and you know the rest of the story. But remember, as I said this, and this is a point you need to know, resistance can develop very quickly with all of those agents. And so that's why from an infectious perspective, they'll be given in combination. Remember, when we talk about tuberculosis, and we'll talk about these drugs later on, and we talk about so that's rifampin, isoniazid, and that plays a lot of issues on the nerves and hepatocytes. We have pyrazinamide and ethambutol, which can wreak havoc on your eyeballs. But the good news is we drop these two off when we treat. I think after 6 weeks, maybe 8 weeks, I shouldn't have this. We don't treat a lot of TB, but you don't use all 4 of these for the entire 6 months or whatever. I think these two, after 2 months, are dropped off, and these finish the last 4 weeks, 4 months, I believe it is. Don't quote me on that, but it makes it a little bit cleaner. But the thing is, isoniazid can cause some neuropathies, no doubt. And it's abbreviated, actually, if you want to remember it. It's abbreviated, isoniazid is abbreviated INH. And remember this, I stands for injures, nerves, and hepatocytes. One way to remember it. So the rifamycin's good. Oral absorptions. Remember the rifaximin now that we use for mainly hepatic encephalopathy, that doesn't have absorption. That's literally just working within the lumen of the bowel. Good distribution in the CSF, but hepatically metabolized, so certainly caution in hepatic failure, and you do have the renal dose to adjust these drugs. And we've talked about rifampin. That's why the rifabutin is used sometimes, especially in HIV patients or hepatitis C patients, is the cytochrome P450 system. The rifampin is a potent inducer, so that's very important to keep in mind when you're giving someone rifampin, because it can induce or decrease the levels of a chronic drug that has a therapeutic benefit to the patient, or you could potentially lose that benefit because of the rifampin. Adverse effects, certainly nausea, vomiting is always a potential, but rash can be there. Hepatic failure, if you're on a rifamycin, you're going to be told to avoid alcohol. Sorry, if you get TB, you're not doing it, but you're going to monitor the LFTs. Doses that exceed the 600 milligrams, you can get a flu-like syndrome, and you can also get hematological disturbances. Now, specifically with the rifabutin, this is very important. You can get uveitis, and you can get skin hyperpigmentation, so you need to do that. Here's your pearl. Now, this is big time too, because it will happen. Any of your secretions of your body with rifampin, it can turn it in orange color. So you need to let the patient know when they're taking rifampin, they need to know that their urine, their sweat, their spit, their tears can turn an orange color. It can stain contact lenses. Wearing an undershirt would be appropriate. If it's a white shirt, expect some orange discoloration where you have sweat. So I think that's a good pearl to note and appreciate, because that can lead to some problems with patients. As long as you warn them about it, they can appreciate it. So that ends that discussion of DNA disruptors. So let's close that out, and let's go back to it should be our, where are we at? That's not it. So we go back down here. I thought I had it pulled up already, gang. I'm sorry. Here's our pharmacology lecture. And again, here's your lectures. We're on week 3, lecture 1 right now. Don't forget to read all your handouts. We just finished up. We would be down here. We just finished up right here. So everything we just talked about is going to be included in these. And next, we're going to go to TB drugs and antifungals. Don't forget your antifungal cheat sheet. You need to appreciate that. So I usually review my lectures before I give them, but I feel pretty comfortable when it comes to talking about fungus and things like that. And your antimycotic, your antimycobacterium drugs. I think that's misspelled. I think that should be myco, and antifungal drugs. Anyway, let's just start talking about them. You know, I don't see mycoplasma, your mycobacteria type infections is like we used to. I don't know. You know the objectives. We've gone through these enough. So the mycobacteria, they're going to be aerobic rod shaped. So it's going to be more of a bacilli, if you will, and highly lipophilic cell walls. So they'll be referred to as acid-fast bacilli. Now, when you treat for these, it's not going to report out admittedly. You're going to send it out. But when you start seeing acid-fast bacilli, you need to start thinking mycobacterial species. And when we think about the most common mycobacterium, don't get it confused with the atypical mycoplasma that you see in walking pneumonia. This is mycobacteria. But the big one is going to be Mycobacterium tuberculosis, and it can be active or latent. And we're not going to really differentiate that. That's going to be for your clinical medicine classes. But we do want to understand the drugs that we treated, and this is going to be primarily our focus. Also, another big one, and we do prophylaxis against this with several drugs, such as a gram of Zithromax every week in HIV patients who have AIDS. Usually CD4 counts less than 100 in this case. We will prophylax against MAC and to prevent the patient getting it. But let's talk about it. So treatment of active tuberculosis, and there it is. And yeah, I did have it right. So your first 2 months, you will have on the ripe, you'll have your rifampin, you'll have your isoniazid, your pyrazinamide, and your ethambutol. And then from month 2 to 6, so the 4 month, the continuation phase, you're only going to have your isoniazid and or zide, however you want to say it, in your rifampin. But this is the backbone for most of the TB that we treat in the US. Now, if you end up with an extremely drug resistant or multi-drug resistant, that changes the game. There's certainly an oral carbapenem that's being tested in China that's showing some pretty impressive results initially for the treatment of your more active tuberculosis. When I say active, more of a drug resistant. In Africa, they used a lot of linezolid and some other combinations, but the R is rifampin, and that can be rifabutine or rifapentine. We see these deployed when we worry about drug interactions. Remember, rifampin is a big inducer. Your second one is isoniazid. So remember, these two dudes right here are going to be going for the full 6 months. And then we finish out drug 3 and 4 with the pyrazinamide and the ethambutol. These dudes here are only going to be going for the first 2 months. So there you go. You got it. Now, here's multiple regimens. There's different regimens you use. We worry about compliance. So sometimes you can have patient observed taking of the medication. It depends. But you can see the different regimens that are out there. And what I like to look at is regimen effectiveness. So there's a lesser effectiveness versus, but these here can be twice weekly. This is when the patient actually comes in and you watch them take the medication at a health clinic. But I like the regimen 1. There's your 4-drug combo, 7 days a week for 56 doses, 5 days a week for 40 doses. But just keep it in mind for your intensive phase versus your continuation phase. But I don't expect you to know this. I think you just need to, in the general sense, need to know this. If you have a patient with active TB, I hope you have access to an infectious disease doctor to at least help you guide the therapy. You're certainly going to have your local or your state health authority intervening and helping you as well to make sure that these patients take it. But just know that you'll see it. Sometimes you'll see they don't have it up here, but sometimes you'll see vitamin B6 given with these. Remember, that's going to be, we do that with linezolid as well. to help with the neuropathy. So if I ask you what drug would we give B6 into addition to try to mitigate a side effect? Well, remember, I told you INH stands for insults, nerves, and hepatocytes. So yeah, sometimes you'll see it given. They don't have it in the regimen. I don't know if they have it down here anywhere. We can see. There it is right there, pyridoxamine. Yeah, there you go, at risk of neuropathies, pregnant women, breastfeeding infants, persons with HIV, almost everybody, et cetera, et cetera. So that's for prevention or mitigation of the neuropathies. When we talk about treatment of latent disease, the isoniazid monotherapy for 9 months or the isoniazid for rifapentine for 12 weeks. I'm going to tell you right now, and it can be rifampin or rifapentine. This is the old one. This is actually only, this recommendation here, I think, is no more than 2 years old. It's not that old. So this used to be the old recommendation for 9 months. Would you rather do this for 9 months with isoniazid or take a combination for only 12 weeks, which would only be for 3 months? I know what I'm going to do. I'm going with this right here. So when you have someone with latent tuberculosis, remember this dude right here. Do this 2-drug combo. But prior to that, we would do isoniazid, INH, for 9 months. And you know the side effects, INH injures nerves, neurons, take the B6, and hepatocytes. Got to monitor those liver. So the mycobacterium focus of the rifamycins, and I said, see their mechanism for DNA disruption for their we won't go into that. But these are your drugs. Your prototypical is rifampin. The other ones are typically deployed when we want to mitigate drug interactions. And a lot of times this is going to be due to HIV medications that are being taken or some of your hepatitis C drugs. So the spectrum of activity are Mycobacterium tuberculosis. Our non-Mycobacterium species would include MAC or Mycobacterium avium complex, but our focus is on tuberculosis, and then infections preferentially treated with it, again, active and latent tuberculosis. The clinical pearls, we talked about rifabutin has fewer drug interactions, so not as much interactions with the cytochrome P450 system. So those who have HIV co-infection, it's an excellent alternative to rifampin to avoid those drug-drug interactions. And then your other one up there, your rifapentine, this has the longest half-life, which allows for less frequent dosing. But this is the one that's the biggest pearl right here, especially in those predisposed patients on various non-nucleoside or nucleoside reverse transcriptase inhibitors, your integrase inhibitors, your boosters, whatever it may be. It gives you a nice opportunity where you avoid those drug interactions and you don't have to worry about as many drug dose adjustments. So the isoniazides next, the spectrum of activity, again, Mycobacterium tuberculosis. This is a very important point. Most of your non-TB Mycobacterium are resistant to this therapy. So what do we use these for? Isoniazid is just used for active or latent tuberculosis. Now remember, in the latent tuberculosis, we can combine it with rifampin or rifapentine, and we can go from 9 months of therapy with monotherapy with isoniazid to what? A nice, what was it, 3 months of therapy. This is big. This is big. So keep that in mind. How does it work? INH is a prodrug that is activated by mycobacterial catalase peroxidase. You'll see that as CAT-G in the literature. And this inhibits two enzymes that are important for that mycolic acid production. You have your acyl carrier protein reductase and your beta-keto ACP synthetase. And again, you're going to get cell wall disruption, cell death. Given in combination, of course, with for TB. The other three drugs initially. Administration, good oral absorption, but we do not take it with food. This is one that you'd want to take. We said nitrofurantoin, one of the few drugs I say take with food. This is one that you do not want to take with food because that can inhibit some of the absorption. It is widely distributed, and you can have TB outside of the lung. I've seen a couple of cases of Pott's disease where the TB was actually in the vertebral column. Hepatically metabolized. So remember, INH injures the hepatocytes and the nerves. So anyway, contraindicated in acute liver disease or a history of isoniazide associated liver injury. So this gets into a discussion of pharmacogenomics of fast acetylators versus slow acetylators. Something we won't get into that, but there is some pharmacogenomic issues with that. Renally excreted, so there are adjustments. Drug interactions come with it, like most of these drugs. The two big ones are phenytoin, which we don't see as much, and carbamazepine, which we don't see as much. Adverse reactions, we talked about the elevated liver enzymes. So 3 times the upper limit of normal, you need the DC therapy or at least hold it. The hepatitis that can occur can be fatal. Remember, it's abbreviated INH. What does the I stand for? Remember, injures, that's just what it stands for. Injures neurons and hepatocytes. So you know the 2 main adverse effects you need to appreciate. The peripheral neuropathies, because it depletes B6 in its mechanism. So you're going to give the pyridoxine, aka B6. You're going to watch for elevated liver enzymes. If it's 3 times the upper limit of normal, you have to hold therapy. If it doesn't return to normal or you challenge and it happens again, you may have to just stop therapy altogether. But the hepatitis indeed can be fatal. Do not drink alcohol while you're on this drug, okay? Or the patient, you need to tell them not to drink it. So be aware of that. But there's rash and fever are certainly potential, but there's the INH. Remember, that's the abbreviation for isoniazid, and injures neurons and hepatocytes. The clinical pearl, again, administer with B6 to, I don't know if you're going to prevent neuropathies, but you can certainly potentially mitigate them. But it depletes B6. So that's one thing you need to keep in mind and appreciate. Okay, so we talked about the R, the rifamycins. We talked about the I, the isoniazid. Now the P, the pyrazinamide. And what do we use it for? This is just for Mycobacterium tuberculosis, and it's going to be in the first 2 months. Okay, the last 4 will be just the rifampin and the INH, but we use it for active tuberculosis, and again, it inhibits essential enzymes for the synthesis of mycolic acid. When you think of tuberculosis, you're thinking mycolic acid. Their mechanism is going to revolve around that. Very well distributed with good absorption. It is hepatically metabolized and is contraindicated in severe renal impairment, and it does get excreted renally, and it requires renal dose adjustments. But unlike rifampin in isoniazid, this one does not really have much drug interactions to speak of, so that's good. Adverse effects, I can tell you the joint pain is real. I've talked to TB patients about it. I talked to one in Africa. I always ask them, did you have joint pain? And the answer is typically yes. So common. I don't know about the nausea, but the joint pain. Hepatitis is a risk, and we talked about that right here. Rash, and you can get uric acid retention. But the good thing is, if it's a patient with gout, it's a low risk of a gouty attack. But yeah, you can increase your uric acid levels to potentially have precipitation of that in your joints. Its clinical benefit, though, as you know, is early on in treatment. So typically after 2 months, it is stopped, as is the ethambutol. Now, ethambutol can be deployed for Mycobacterium tuberculosis and some non-tuberculosis mycobacterium. But where do we use this? We use it for active tuberculosis. And again, its mechanism, I'm not going to go into a lot of that detail, but we're talking about synthesis of mycobacterial cell wall. If it sounds like I'm going through these fast, you do need to know this information, but I don't really consider this high yield because it's not, you're going to see TB in your career. It's not as rampant now in some places, but it depends where you are. If you're in highly populated areas with a lot of migrants, you're going to have some issues with tuberculosis. So good absorption, but we take this in with food. Minimal, good distribution, but minimal CNS. It is metabolized in the urine, renally excreted, so you do need to appreciate a renal dose adjustment. But as with the pyrazinamide, no drug interactions. Adverse effect, this is the one I want you to remember, just like I mentioned, this begins with E. I begins with E. So think of optic neuritis. So you have the risk will increase with higher doses in those who are renally impaired. It will create a red-green color blindness with associated blurred vision. So you're going to have to do a vision test monthly. They do this also with linezolid because it has a high propensity when you take it long-term, or a higher propensity because optic neuritis, which in and of itself can lead to blindness. So you can get uric acid retention along with the ethambutol as well, just like with the pyrazinamide. But again, remember, this begins with E. E is I. I is the optic, so think of optic neuritis, okay? So this is a very tough combo. If you're giving this, I'm not sure. I wish the guy's name is Joseph Sancook was the ID guy in Africa. He's great. I didn't really get a chance to talk to him in detail about ethambutol and their combinations. I should have, because with the optic neuritis that you can get with linezolid long term, I don't know. Now I know what I'm going to look up tonight because I got to know. I got to know. I won't waste your time looking it up now. But I don't know if you would use linezolid in combination with ethambutol for an extremely drug-resistant tuberculosis. I don't know if that would be a good strategy and the risk of compromising their eyesight. Anyway, that's going to take us away from pretty much a lot of the bacteria. So we're going to jump into the antifungal world, and so much is changing. If you keep up with the news, you're hearing about Candida auris. I think that's how you say the species, but it's AURIS. I don't think I have that incorporated into my lecture. I think the big takeaway there is we don't have really any treatments for it. But when you think of Candida infections, maybe you have a yeast infection, or maybe there's a urinary tract infection. When you think of fungal infections, these are typically patients who are immunocompromised and have a lot of other things going on in their world. So it's not as simple as 1, 2, 3. You're not going to walk down the street necessarily and catch a mold, mucor, mucosis, or fusarium, or something along those lines that are going to mess you up. But we're going to talk about them. Amphotericin used to be our quote-unquote big gun. We called it amphoterrible. We'll talk about it. Flucytosine is an excellent drug to give for cryptococcal infections. We'll talk about it. It is actually metabolized or broken down into 5-phenyluracil, what we refer to as 5-FU, the abbreviation. So that's another one. The echinocandins, they just came out with a once-weekly echinocandin. Echinocandins don't really cross the blood-brain barrier, and they're inherently resistant to cryptococcal infections, so that doesn't give us really much to go by. The amphotericin is pretty much a cryptococcal. We can do one dose, but the other one's the triazoles, and the one you probably are all familiar with is fluconazole. Many of you may have taken it, but you can look at the other ones down here. When I think of tenaftate, I think of ringworm. When I think of nystatin, I think of diaper rash. We'll go over all these, but the antifungal drugs very important. So when we talk about our fungi, you have your yeast, right? And your big ones are going to be your candida. I know it says candida, but it's pronounced candida. So think of DADA. But your candida species, your big one is going to be albicans. So I need you to remember that. That's going to probably be 80% of your pathogens. And fluconazole is great for that. Okay, albicans. Pretend like it albicans. So one, albicans, I'll just put an A for that. The second most common, which can be anywhere from 10, 15%, are going to be Candida glabrata. Now, fluconazole is good for glabrata, dose dependent. You have to give higher doses. So keep that in mind. The next one is probably going to be, oh gosh, I just went blank on Candida, but the next one most common, well, these are probably all equal share, but you're going to have parapsilosis. You're going to have tropicalis. That's another one. I'm trying to riddle all these off the top of my head just while I do this. It's late in the day when I do this, but I'm going blank. I'm not going to cut you short though. I'm gonna pull up my phone here and oh, I don't need to look it up. Crucii. That's the one. When you hear Candida crucii, let me get my timer back up sometime in the lecture. When you hear crucii, that's going to be one that's probably going to be right here. That's the one that's inherently resistant to most azoles, specifically fluconazole. But when you talk about yeast, your most common are going to be your Candida species, and there they are. The Pneumocystis jirovecii, the pneumocystitis, that's the one what you see when CD4 count, immunocompromised, but a lot of times when CD4 counts get less than 200. Now remember our drug of choice for this, you remember what it is? It's Bactrim. And we will do prophylaxis in patients with AIDS when their CD4 count is less than 200. The Cryptococcus neoforms, this is something we typically see invading the CNS. It's more of a meningeal infection. And we'll treat it with now just one dose of amphotericin, and we switch to fluconazole, usually for up to 14 days. This one's pretty interesting if you ever see it again. Immunocompromised people get these. So this is immunocompromised. This is immunocompromised. What you'll see is a ring enhancing lesion on the CT. Those that are modes and yeast, these are dimorphic. So this is your blastomycosis, your coccidioideomycosis, your histoplasmosis, your spiral trichosis. Now, how do you know the difference? I'm going to give you a little rhyme, a little jingle. Yeast love heat, modes love cold. So these in heat in the human body are going to be, they're going to present as a yeast. But in nature, if it's cold, they're going to be more molds. So yeast like heat, molds like cold. What are some of those that are all molds? Your big one, and this is all immunocompromising, okay? They're dermatophytes with fusarium and stuff, but aspergillosis, human goddess is going to be your big ones. Mucormycosis, we're seeing more and more of that because we're getting better at what we do, and there's more immunocompromise in chemotherapy type patients. But this one's your big dog, your aspergillosis. I have seen a couple of cases of mucor and fusarium. Mucor, these were both in the nasal carriers, and one was on a little abscess. But this year, if it disseminates back in the day, we still don't really have good options for it. It was a death sentence. And until your immune system, your ANC is usually shot at 0. So your bone marrow's been ablated for chemotherapy, whatever. That's why they say I isolate patients in those regards. It's very important. They're hard to treat. But the sites of actions of antifungals, when you look at them, like these are the triazoles, so the endoplasmic reticulum inhibiting that ergosterol synthesis, that's a cell wall type phenomenon. The same with the echinocandins, that's a big one. The polyenes down here, plasma membrane, but this is probably pretty good. I would memorize this actually. I would appreciate this and just know that where each one of these groups, but your big groups, that's a big one. That's a big one. That's a big one when we're talking about, and that's a big one when we're talking about keeping people alive. And excellent spectrum of activity. I don't think Candida auris is on there. So albicans, if you notice, that's what I was going over. I wasted all that time trying to write this. Notice with albicans, though, you get very nice coverage of all the way across the board. The crucii with fluconazole, that's the one you need to make note of. This is intrinsically resistant to fluconazole. With the glubrata, that's the one that I said sensitive dose dependent. So you would have to probably give a 400 milligram dose at minimum to cover glubrata. Now remember, fluconazole is really the only one in ampho, these two that get in the urine, but you wouldn't want to really use ampho if you could all avoid it. But you can see the other ones, parapsilosis tropicalis. Fluconazole is going to cover it, no doubt, albican. So fluconazole is still a workhorse. There's your Cryptococcus neoforms. If you notice with your echinocandins, no bueno, no good. They're intrinsically resistant. So something you need to keep in mind because, well, first of all, they don't really cross the blood-brain barrier, but second, they don't work. But there's your flucytosine. So I can tell you the treatment for this is we predominantly, it used to be 7 days of amphotericin. New studies come out. We do a one-time dose of amphotericin, as we call it, and then we back it up with high-dose flucytosine and high-dose fluconazole. But I'm not going to go through all these, but you can see it's a pretty good chart. And there's the aspergillosis species, and there's the human goddess. I've seen Niger, I've seen Flavus, I've seen the Terra, I've seen all these, but just notice that when you talk about aspergillosis species, amphotericin used to be your drug of choice, but voriconazole, this is considered your drug of choice. Now, yes, itraconazole is out there, but we don't really like it for many reasons. There's a lot of drug in posaconazole, noxaphil's out there. Now you see, hey, the echinocandins cover it. Their studies have only been in salvage therapy. You could add it to it, but when you think of aspergillosis, your drug of choice is voriconazole. That is the new recommended guideline through NCCN and all the ID societies. But this is the main one you're typically going to see from a genus species perspective is the human goddess. But albicans is your most common species, B1. Tropical or Glabrana 2, and just go down the line. This actually breaks them down in most common to least common. Okay, so that's enough. This is a good chart to know. Amphotericin B, let's start with this. So if you notice fungizone, this is the regular amphotericin B deoxycholate. This is what we had. It was riddled with side effects, specifically acute kidney injury. That was the big thing with it. So they came up with these lipid drugs, and the lipid drugs were more renal protective, meaning less likely to cause acute kidney injury, so a decreased risk. Now, the one that I think is the best, so ambisome is a liposomal drug. You need to know that, amphotericin liposomal. The Amphotech we don't see anymore. The Albacet is a lipid complex, so I want you to follow me here. Okay, Greg, you do a lot of ID stuff. When you saw the histoplasmosis, or you see aspergillosis, or you see cryptococcus in your consult to pick the drug, why do you go with ambisome? I'm going to tell you why. So with amphotericin, and you're going to see these on the other slide, the biggest issue is acute kidney injury. We were able to mitigate that with both of these drugs, the liposomal amphotericin and the lipid complex. The second thing with these drugs is they call what we call shake and bake. They can cause infusion-related reactions. If I had to tell you which ones had the most infusion-related reactions, Abelset is one. Fungizone is two. Ambisome is the most tolerable. So that's going to be reason number one on formularies and why I go with ambisome. Now, from a mitigating acute kidney injury, there's no difference between ambisome and Abelset. So I'm at ambisome right now, second from a therapeutic perspective, not a side effect perspective. Why do I like ambisome? It's a little bit bigger molecule versus the Abelset. So it's not cleared as fast. So there's more time for it to have exposure to the blood-brain barrier. And because of that, it tends to get better penetration in higher concentrations in the CNS. And that's where my cryptococcal neoform infection is. And so that's why Greg Perry prefers ambisome. The least shake and bake, Abelset probably has the most, and it gets higher penetration. That's why I do it. Now, can you mitigate the shake and bake? You can. You can pre-medicate the patient with the fever they get. You can pre-medicate them with acetaminophen, 1,000 milligrams. You can potentially give some Benadryl, but I'll tell you something that works really nice in these patients is as I take a sip of 5 Hour Energy, is giving meperidine, Demerol. But I don't even know if hospitals carry that anymore. It's kind of a no-no drug because of metabolites and some risk of excitation and making you see crazy stuff. But it's very good for shivering. And remember, shake and bake. You're baking the fever, you gave acetaminophen, and then the shake, the shivering, you can give meperidine if other interventions don't work. So keep that in mind. But what do we use these for? It'll cover, this is Spectrum, but we would not use it for Candida albicans. We're going to use fluconazole. We do, no doubt, use it for aspergillosis. Now, cryptococcal infections, it used to be at least 7 days, and then we'd switch to fluconazole. We would have flucytosine on board as well. But now there's a regimen where you can just do it for 1 day, and you can go to flucytosine and fluconazole. Certainly the other ones, histoplasmosis, coxardioconsosis, and blastomyces, yeah, no doubt. But, and it used to be the drug of choice for aspergillosis, but now we use voriconazole. So it's not deployed as much as it was. And that's a good thing. It was a great drug while we had it. We've done some central line locks and things like that with it before too, but keep that in mind. The infections we preferentially treat, it's going to depend. But remember, these infections we're talking about, these are immunocompromised patients. If you ever work in a transplant center, especially a bone marrow transplant center, you will become very well versed on these medications we're talking about. Okay, so when we talk about it, when you talk about fungus, ergosterol is a big thing, and that's what we're doing. It's gonna interact with the ergosterol, however you want to say it, the ergosterol on the fungal wall, and you form a pore. And again, it's going to be based on electrolyte formation. In these cases, those pores are formed, and that allows potassium specifically to leak out of the cell. And that leads to the cell death. So fungicidal, fungistatic, depending on the organism, I'm not going to go into that. And you have a nice picture of its mechanism of action. But you need to appreciate from a pharmacology perspective, especially being tested, the mechanism of action. So we administer it very slow. I told you why. You can get shake and bake. Remember, that's going to be some fevers, some chills, some tachypnea, and we can premedicate with acetaminophen. We can premedicate plus or minus an antihistamine or a steroid or all the above, and that helps. If that doesn't work, with the shivering, you could consider coming in with very low dose meperidine, 12.5 to 25 milligrams. You don't need a big dose in this regard, but that would be something if you couldn't get the shake taken care of. It has a good distribution, including the urine, which is nice if you have something in there, but I'd rather do a bladder irrigation before I would do systemic with this stuff. But then there's no hepatic dose adjustments, but renal dose adjustments are required. Now remember, its biggest substantial side effect is acute kidney injury, and that is 100% reason why the lipid complex and the liposomal were brought to the market, was not to get rid of it, but it decreased substantially your rate of acute kidney injury. But the drug interaction, you would want to avoid other nephrotoxins, but you can have phlebitis. We would prefer a central line. The renal impairment, I forgot to tell you this, sometimes when you see amphotericin, pre and post dose, you'll see a 500 ml bag of NS given. This has been shown to help prevent renal impairment. So IV fluids prior to administration, we use the lipid-based forms now to mitigate that, but you can give 500 mils before and or after if you want to, just to make sure you're hydrating the kidney. Now, a big one you need to watch for, you will have, it's not a Fanconi syndrome, but it seems to play that way, but you will have loss of magnesium and potassium, specifically potassium. Trust me when I say this, if you see a patient if you're working as a hospitalist and ID has a patient, you as the attending, they're going to expect you to keep an eye on those electrolytes. Watch that potassium. You will have to replace it. Trust me, it will deplete enough where you need to give some systemic boluses, whether it be oral, which is fine, or IV. And then the liposomal formulations, remember, those are associated with reduced renal function and infusion-related toxicities. They're not as expensive now, but they are more expensive. Now, remember, though, when my experience and in studies, when you look at the shake and bake, it was the lipid complex, the Alpacet, that was more likely. The conventional was second, and then the one that had the least amount of shake and bake, not none, was the liposomal, which was the Ampazine. Okay, so we're going to leave amphoterol. Make sure I didn't leave anything off. There's a lot going on there. There's certainly a lot of test questions tied up in there. The good thing is we don't use it as much. Flucytazine, this is Oncobon. It's metabolized into 5-fluorouracil, but the main use of this is going to be for your cryptococcus in combination with fluconazole. And then what we use it for typically is part of a combination treatment for cryptococcal meningitis. For Candida infections, we certainly have better options. But how does it work? There it is. Think of cancer. Flucytazine, you can see it going through breaking down to 5-fluorouracil, breaking down into F-dump. You're going to get an inhibition from dump to DTMT. Thymidylate synthetase inhibition, boom, there you go. You're going to have decreased DTMP right there. You're going to have, which leads to DNA. If it doesn't lead to DNA, you've inhibited DNA synthesis. You've inhibited cell division. So there, it's going to disrupt DNA and protein synthesis. So now we've talked about ergosterol activity with amphotericin. That's where it's working up here, right? And now we've talked about disrupting DNA and protein synthesis in the fungus through the use of flucytazine and its mechanism of action being broken down actually into a drug we use quite often for chemotherapy, specifically some of your gastrointestinal type tumors, leiomyosarcomas, and colon cancers, if you will. So flucytazine, I believe it is only oral. It has good absorption, excellent penetration into the CSF. That's why we can use it for cryptococcal meningitis. It does require renal dose adjustment. But the thing about this, you have to be careful. It can come with some pretty profound hematological disorders. So you have to monitor their CBC. No real drug interactions to speak of, but nausea is common. You can have associated vomiting and diarrhea. And there are the penias, the agranulocytosis type things, but reversible, that's the key. Reversible neutropenia, and then low platelet count, thrombocytopenia, and you can have some reversible hepatic dysfunction. So you're going to monitor that CBC along with that comprehensive metabolic panel, which is going to give you your LFTs. But clinical pearls, to monitor drug levels, we don't always do that. I typically do. And because I want to level, the reason I do is I want to make sure I'm therapeutic, but I don't want to be super therapeutic because I don't want all this crap going on. US box warning ties into all this stuff up here. Closely monitor hematological, renal, and hepatic status. So at least once a week, you're going to be getting your at least LFTs, but you're going to be getting that CMP because that's going to give you LFTs. That's going to give you your serum creatinine, and then get that ever mentioned CBC, that complete blood count. And then US box warning again, used with extreme caution in patients with renal dysfunction. Now remember, anytime you see a US box warning, black box warning, that's always fair game for a test right there because it's a safety issue, and safety is something we don't compromise. Echinocandins. There's a new one. It's called regimafungin. It's REZA. I'm looking up in the sky. Rezulfungin. I think it's REZAULFUNGN. Anyway, it is IV. The difference with it is these are all more daily. This is once weekly. I do have a strategy for it if the opportunity presents itself. Candidemias, again, even if this did cross into the CNS, it doesn't matter because it's inherently resistant to Cryptococcus. But its spectrum activity, aspergillosis and Candida species. Now, for the most part, it covers all Candida species. If you look at MICs, and we do have established MICs for Candida species, you'll see with parapsilosis, it's a little bit elevated. That was kind of a concern at first, but I don't really get concerned with it because when you look at the outcomes, there was no change in the outcome. So, but I'm using fluconazole because parapsilosis is inherently pan-sensitive to fluconazole. And with fluconazole, I can do a 1-to-1 IV to PO switch. But anyway, I don't think there's a prototypical drug. Micafungin is what I've always gone with, and that's because they did studies. The original indication was 150 milligrams daily, but they did some studies that showed 100 milligrams daily was equally efficacious for treating some of your candidemias. And that was important because it's cut the price down. These were extremely expensive drugs when they first came out. This caspofungin, this was the first one that came out by Merck, Cansitis. This dude was running like $500 to $700 a day when Araxis and Igilafungin and Micafungin came out. Micamine, they substantially decreased the price down to like $300 a day. And so, but I went with Micafungin because it was the cheapest of all. Remember, when all else is equal, I base things on three things: cost, cost, and cost. So Micafungin is the places I've always been. I've had it switched over to Mica as the formulary, but Cansitis, you don't really see much. I think this is actually twice daily. I know it has more drug interaction, so it's just something I don't go with. But it is, you need to remember, it is kind of Candid. They're all going to end in fungin, but it's out there. And Araxis is another one, Anigilafungin, that's out there. I think that one does require, both of these two, I think, require a loading dose. But the spectrum of activity for all of these, they're all very good drugs. I just prefer Micafungin because it was cheaper. It was the cheaper. Remember, cost, cost, and cost. Aspergillosis, what I need you to know is, yes, you can use it for aspergillosis, but it's more third line for salvage. But it does cover it. But we're going to be using these for Candida, and more specifically, candidemias, when we know you're going to get a culture that says yeast in blood. That's the first thing you're going to do. And you're thinking, well, why can't we just use dirt cheap fluconazole, Greg? And you can, but the thing is if it's a glabrata species, which is sensitive dose dependent, or a cruci species, which is inherently resistant, then you have a bug drug mismatch and you're not treating the patient. So once you get, though, if you know it's yeast and it comes back as Candida, and then once it comes back as a species that's not albicans or not crucii, absolutely you can change to fluconazole high dose. I like to do 12 mg per kg times 1 and 6 mg per kg daily. Some will just do the high dose 400, but you run the risk of underdosing in that regards. I've had that debate on how do you dose fluconazole. I dose to cure. I know that the therapeutic index is pretty high. Yeah, if you get the doses too high, you can cause some adrenal suppression, specifically from I don't know which part of the zona in the adrenal gland, but it can cause some testosterone deficiencies. But I think you have to get up around 1,200, 1,500 milligrams to get there. I'm not going that high, but no means am I going that high. But I don't think 400 milligrams is necessarily appropriate for a candidemia, but it works. Anyway, you can read the literature yourself. I'm not going to get into that. But point being is you can change it as soon as if you get the right, once you get your culture and sensitivity back. And the beauty of it is when you treat it, when you get your first negative culture, you treat it. So you're going to be drawing serial cultures like every 48 hours or so. When you get your first negative culture, you're going to treat it for 14 days more. And that's what you're going to do. So what do we use it for? The echinocandins, though, we use them for, whether you use it for fluconazole or an echinocandin, but we use it for invasive candidiasis, including candidemia. Now, when you think of invasives, one thing I want to tell you, you're going to grow a lot of candida and yeast, well, not a lot, but you're going to see sputum cultures growing candida, and there's really no such thing as candida pneumonia. I think the rate is far less than 1%, but yet you see it treated. Now, if you have a patient who's sick, their white count's not improving, they have persistent fevers, and there's things going on, their urine's growing fungus, their lungs growing fungus, it behooves you to start an antifungal, in my opinion. But where we see these, it's going to be candidemia, and then it's going to be esophageal candidiasis. Now, if you have thrush, you can use topical Misalex troches or nystatin spit and swallow, or spit, or swish and spit, swish or swallow, whichever one. But if it's in the esophagus, you have to use systemic therapy, and we'll see it with prophylaxis for prior to stem cell transplant. But your main treatment is going to be invasive candidiasis, mainly candidemia, until you get your culture. And remember, it's going to show up yeast in blood, then you're going to get candida, and then it's going to tell you your species. Once you get your species, once you know the genus, that's when you can decide, can I de-escalate the fluconazole? And you should as soon as you can. It saves the hospital money. But how does it work? Echinocandins, so these inhibit the synthesis of beta-1,3-D-glucan. This is used for the creation of the fungal cell wall. In essence, it leads to cell lysis and cell death, so it is a fungicidal agent. Now, you're going to see that you can actually order beta-D-glucan test, and there's another one for aspergillosis you can order called the galactomannan. I'm not the biggest fan of the galactomannan. I'm going to tell you why. The galactomannan tends to spike a little bit early and then go down. And if you test it, like this is day 3 to 5, and you test it like on day 6, and it's not there, you're going to get what we call a false negative. And you have an aspergillosis infection, but your test, so it is a tool to check. If you're going to get it and you suspect it, order a galactomannan sooner than later. I've seen some ID docs trash the beta-D-glucan test. I don't know I'm not an ID, I'm an ID pharmacist, so my perspective is I consider myself an expert on pharmacotherapy. What are the best therapies based on the benefit to the patient while mitigating safety? As a pharmacist, my training's not in diagnosis. Yeah, I can pick out some things. But when it comes to the bedside and the patient, I don't. That's not my wheelhouse. That's not my lane. I'll have discussions with providers. Hey, you think it might be this? And when I'm right, I feel so proud of myself. But that's not typically the case as a pharmacist. So I've recommended the test before, but these are things you're gonna have to massage out on. And some of you will go into ID. And I'm gonna tell you right now, as a non-physician, I think nurse practitioners and physician assistants are very well set up to do infectious diseases in hospitals, especially if you have a physician who's an infectious disease doctor who has a very robust outpatient clinic. I think it gives you a lot of opportunity to get a lot of professional fulfillment working within the hospital. Now, for those of you at the school, some of you have, so Dr. Rachel Wrighton at United Regional, she's a DMP, and that's exactly what I'm talking about. She does a phenomenal job. So, and that's someone you can rotate with. She's part of the team at Hardin Simmons as a preceptor. So she would be a classic example of someone, the benefit of an APP within the hospital setting, working with an infectious disease doctor. So just something to keep in mind as you look to your career. ID, I just migrated to it because of my time, because of Larry Martinelli, actually in Lubbock, Texas, when I worked at Methodist, it became Covenant. He taught me so much, and I was just fascinated the way he knew. He just knew stuff. Some people just impress you with their knowledge, and he was certainly one of them. But anyway, I digress. Let's keep moving on. So, no renal dose adjustments are needed. The hepatic adjustments are required only for caspofungin. It's one of the reasons I do it. Remember, they do not distribute to the cerebral spinal fluid nor the urine. I will see providers order micafungin, caspofungin, anigilafungin for a candida UTI, and you have to use fluconazole, or you have to use amphotericin, which we don't want to use, conventional, maybe some bladder washes. But remember, if it's asymptomatic, you really don't need to worry about it. The drug interactions I mentioned, again, one of the reasons we ditched caspofungin, it was the first one on the market, was because it did come with drug interactions, so that wasn't worth it. The mica and the nidula were clean of drug interactions, and the mica was the cheapest. So from a formulary perspective, it gave me all the reasons in the world to dog that and keep this. Adverse effects, you will see some patients complain of this histamine-like reaction if it's infused too quickly. That is real. We saw that initially, but if you slow down the infusion, you're not going to have it, but you can see the potential for some renal or liver toxicity or impairment, and then some hemolytic anemia. But common, I don't even know if these are common. I've never experienced a patient having issues with the kind of candidates. They are very, very, very well tolerated. But all require loading dose except micafungin. That was one of the reasons, another reason we went through it. And remember, you cannot use these for meningeal infection or CNS infections, nor UTIs. I think you need to understand that and appreciate it. Remember, our very first lecture on antibiotics is it may work in a petri dish, but if it doesn't get to the site of infection, no good, no bueno. So the azoles, these are the big ones. Your fluconazole, this is your workhorse. Your itraconazole, we still see it every now and again, especially in some prophylaxis. Posaconazole, noxaphil, we'll see this some. Voriconazole is now the drug of choice for aspergillosis. And isobuconazonium, also, this is IV and PO. This is IV PO, this is only PO, this is only PO. Voriconazole is IV and PO. The double checks are IV and PO. This Prosimba is the name of this, but it's IV and PO. This one is relatively new, maybe 5 years. It actually has an indication for mucosis. So something to keep in mind. I don't think it has an indication for fusarium, but it could be deployed for aspergillosis as well. But this was more mucor. Your imidazoles, these are going to be more your topical, your topical creams, your vaginal suppositories. Some of these do come in a tablet, but topical. Ketoconazole, for the most part, topical. Meconazole, I could go down the list, but these are going to be more for your ringworms, your jock itch, your athlete's foot, those cutaneous infections. It says it right there, versus systemic infections. So azoles, how do these work? This is inhibition of the 14-alpha demethylase, right? Enzyme. So it's blocking the demethylation of lanosterol to what? There's that ergosterol. That's what amphotericin was working on, remember? And it disrupts the membrane structure, inhibits cell growth, boom, fungistatic, and you kill your bacterium. Your main products there is your diflucant or your fluconazole. This is the prototypical drug. Remember, though, if it's Candida krusei, it's never going to be useful. If it's glabrata, you're going to have to outdose it. So no good for krusei. For glabrata, you're going to have to outdose it. Your sporanox, your itraconazole, we still see some. Quasiconazole, we will still see some. Voriconazole is your drug of choice for aspergillosis now. We draw therapeutic levels on this. And then Prosimba, your isobuconium, again, you can see the ones that are IV and PO. But when we talk about the spectrum of activity, remember, fluconazole has the most narrow spectrum and does not cover aspergillosis. Sporanox, itraconazole does, posaconazole does, voriconazole does, isobuconium does. These all cover aspergillosis. Fluconazole does not. And then some of your resistant Candida species, specifically glabrata, more specific Crucii. So, gosh, infections we use them for, where do we start? It can be just a vaginal yeast infection to a full-blown candidiasis, a candidemia, a differentiated candidiasis. So yeah, there's a lot going on with these drugs. They're very good drugs. They're relatively safe. Fluconazole is going to be your safest. They tend to have more risk of drug interactions. I think isobuconium is probably the safest one out there, but it's expensive. Very high bioavailability, so it's a nice option orally. The itraconazole, this has a lot going on to it. You need more of an acidic environment to do it. So with the posaconazole, now take with the fatty meal. The joke with posaconazole, that's the noxaphil, was that you need to take it with a Whopper. And I was only halfway joking. You needed a high-fat meal for it to be absorbed. They have a new formulation that's a lot more friendly in that regard, but that used to be the thing. With the voriconazole, that was more of a avoid with meals within 2 hours of a dose. And the itraconazole, this was avoid taking with antacids within 2 hours. If you were taking PPIs or an H2 blocker, they would say take it with an acidic drink to maximize your absorption. But they're widely distributed. Renal dose adjustment is needed with fluconazole, itra, and vori. Hepatic dose adjustments are needed with vori and itra. Now, I can tell you with voriconazole, let me just tell you now, if you're working at United Regional and you order voriconazole and Greg Perry gets the order, I'm going to be ordering levels. And here's the problem. You give the drug as it says. Now, what you want, and don't look at the lab values. This is from literature. You want to have a level, a trough greater than 2. You want to have you don't want a trough greater than 5, so 2 to 5. I like to have it around 2. When you have levels greater than 5, you start having the more profound side effects, whether it's vision or cutaneous, whatever it may be. But you do it, you give it, and let's just say this is the level for 2. You give your doses, and you're cruising right around here. You're doing good. You draw your level at day 7, you're there. You got to draw it again, because I don't want to call it a self-inducer, but you'll draw it again, and your level will be less than 2, your trough. And we know that for aspergillosis, you need to keep it above 2. Now, I think it'll say keep it between 1 to 1.5 as a trough, but we saw when we had the fungal outbreak from New England compounding centers when they were making steroid injections that were contaminated due to poor sterile product techniques. They were injecting fungus into people's spinal columns, and it caused some profound morbidities and mortalities, unfortunately. But yeah, this is when we established this is the best level, but keeping it less than 5 to mitigate the side effects. But I always like to keep it greater than 2, but I don't like to go greater than 5 because that exacerbates your side effects. All of them run the risk of potentially having interactions with your cytochrome P450 system. So common side effects, it varies between your typical nausea, vomit, headache, skin rashes to the visual and disturbances and hallucinations, which we see only with voriconazole. But this is going to be more associated with your higher levels. So between the 2 and 5, keep your troughs, just a little bit above 2, and you're going to be fine. They are teratogenic, so you do not give to pregnant females unless there's no other option. There's always a risk benefit. If it's just a simple candida infection, heaven forbid, you're not going to give certain drugs. But if it's a situation where a patient is going to die because of a raging aspergillosis infection, you have to weigh the risk and benefit. Now, itraconazole no longer comes in IV, but the IV voriconazole, that is formulated with cyclodextrin, and it accumulates with renal impairment. What I will tell you, if you look, I don't know if they changed the formulation, but if you look at IV voriconazole, it'll say it's contraindicated in creatinine clearance less than 60 mils per minute. And the reason for that will tell you because of accumulation of cyclodextrin. Studies have now found that even in patients with end-stage renal disease, the accumulation of cyclodextrin does not create an issue, meaning you can use it in all comers. Do not hold the drug just because, well, I can't use that. I'm going to have to go to info. No, you can use voriconazole, even though it says that we do it often. Again, we're not using voriconazole for a vaginal yeast infection. We're using it for someone who has a true aspergillosis infection, whether it's in their lung. Typically, that's where it is, and that varies. If you have a aspergilloma, sometimes we're treating we're not necessarily giving antifungal. So there's a lot of differentials that go into treating a fungal infection. So you have to appreciate that. But sometimes the drug books will tell you not to do something, and it's like, okay, they're going to die if I don't do it. Well, I'm not worried about cyclodextrin. And again, the studies are out there, and if any of you ever want them, I have them all. I don't say something unless I've read about it and it's something that was valid. I can certainly send it to you, but cyclodextrin doesn't cause an issue in patients with renal dysfunction, even to the point of end-stage renal disease. So keep that in mind. And there's the drug recommendations for Itravori and Pause. Posaconazole's new formulation is nice because you don't need the fatty meals like you once did. Now, the imidazoles, these are going to be the things you can see here. You're getting trichophytins, your mycosporums, your epidermal phytins. These are things topical. I'm thinking of ringworm. I'm thinking athlete's foot. I'm thinking jock itch. Those are the things I'm thinking about when I do this. Vaginal yeast infections, those are what I'm thinking about. And so they're going to be topical. Again, you can see it's going to be more of a contact type issue, irritation, dermatitis, whatever, but you can see the products, and I'm not going to go into them. Lotrimin is topical. I mean, the butyconazole is topical. Clotrimazole, PO are topical. I think that's the Mycelex troches, I think, that you can do for if you have an oral fungal infection. But ketoconazole, PO topical. When I think of Nazaril, that's another one out there. I think of more dandruff. Taenia capitis maybe, but meconazole, you can go through these, but the imidazoles, those are going to be topical. Then the squalane epoxidase inhibitors, this is going to be your Lamisil, which you'll see used still for, I think, I don't know, it's always butch this, but onychomycosis. Did I say that right? Toenail fungus. Now, you have to take oral therapy to cure a toenail fungus, and pretty much you have to just keep it in that this is your toenail and the whole thing has fungus. And this is where your cuticle is of your toe or your finger. And the whole idea is to keep it out of all this back here, and you don't have any further expansion, and this grows out, and you're only left with healthy nail. It's going to take 2 to 3 months of treatment. And sometimes they do pulse therapy, but Lamisil is when they did that. You certainly need to watch for liver dysfunctions, and then you can see some of the other ones going on out here. But yeah, there you go. But where do we use these again? Taenia infections, Taenia capitis, et cetera, so on and so forth. What's the mechanism of these squalane epoxidase inhibitors? You're looking at inhibiting the squalane epoxidase. So you're blocking the synthesis, there we go, of ergosterol, which means it's going to be static at that point. And so just something to keep in mind. And squalane builds up in toxic amounts, which increases membrane permeability and cell death. And there you go. That's how these work. And again, ergosterol being important in our process on antifungals. Administration, the PO, you can get deposits in the skin, nails, and adipose tissue. It can accumulate in breast milk, so we do not give these to breastfeeding females. Contraindicated in hepatic disease. Now, remember, I told you Lamisil, you're going to be checking your LFTs. There are risks of drug interactions. And then here's your common side effects that you need to be aware of and appreciate with these drugs. But you're not going to see these as much. Lamisil, yes, you may do it. And then some miscellaneous agents. You have your griseofulvin. These are nice. They cover Taenia corpus, cruis, capitis, pedis, inguinum, fungistatic. You know the stories. Contraindicated in pregnancy and porphyrias. And then your nystatin, which is very nice. This is one you will use quite often in the hospital. It comes in an oral suspension, which is good for mixing it in magic mouthwashes. So it's good for swish and spit. It's good topically for diaper rash. If you all remember, that's part of my super B paste phenomenon. So topically, but there's also a topical powder that you can put in the rolls of of adipose tissue or underneath breast when there's a moist area where those budding yeast can do their thing. But you can use that for candida infections of the oral pharyngeal type, cutaneous type, the vulvovaginal. Sure, the oral formulations can cause nausea and vomiting, but we usually do a swish and swallow when we're doing the oral. But you'll see this used topically quite a bit. You'll see it deployed in magic mouthwashes. And again, remember, my little thing was zinc oxide, 120 grams. That's a 4-ounce tube. Then I would do 60 grams of nystatin ointment, and I would use 1 pack of Questran, and I would triturate that in 30 to 60 mils of Maalox. And then once I got it somewhat dissolved, I would mix all these together, and I would make a nice pharmaceutically elegant, it's a pinkish color ointment. And I put it in a 4-ounce jar. I'd make my nice little pigtail on top. When you put the lid on, if you took the lid off, you would not see drug on the top of my lid. That means it's pharmaceutically elegant. That might not mean much to you, but it means the world to me. Trash in, trash out. But this is called, I wish I knew how to make this. It has some prescription items. This is prescription, and the Questran is prescription, but I wish there was a way I could mass produce that and call it Super B paste. It is magical. So if you're wondering why I do it, think about the antifungal elements in diaper rash, okay? The nystatin, right? Think about the acidity sometimes of bile acids, the Maalox. The Questran is bile sequestering. It absorbs stuff, so that makes sense right there. And the zinc oxide is a protectant, so think about that. So I covered all 4. And I'm telling you, parents would call me up at the children's hospital. Their kid would be in ICU, diaper rash wasn't uncommon, and they'd say, Greg, we remember you, because I was always around. I'm a very visible pharmacist, and I was always down there talking to families, just being a part of the team, right? Out of sight, out of mind. Got to be part of it. You got to be down there if you want to be part of it. So anyway, I was in the PICU the entire day. I would spend my entire 10 to 12-hour day in the PICU or the NICU. And you'd get to know the parents, and the docs would say, Greg, make up some of that paste. And the parents would see it and they would love it, and they would leave. They'd call me like they'd have a second child like 3 years later. And hey, is there any way I can buy some of that butt paste? Well, I couldn't do that because that would be illegal. But if any of you have an idea on how to mass produce this, let's do a patent and get busy and make some money. So some of the other ones you'll see, the cycloporox, the tenaftate, again, seborrheic dermatitis here, your dandruff, but tinea pedis, you all get it. Boom, boom, boom. So Tinactin back in the day was referred to tough acting Tinactin. When I was an intern, I worked at High Plains Baptist Hospital in Amarillo. Now it's called Baptist St. Anthony's. But I would go around to the pharmacist and I would put a can of Tinactin spray behind my back. And I would say, what do you recommend for athlete's foot? And I wanted them to say something other than Tinactin, because then I could pop it out and say, no, it's Tinactin, #1 recommended by pharmacists. Now the commercial says #1 recommended by athletic trainers. But anyway, I had a lot of fun with that and messing with pharmacists. So that ends the fungus. So that takes us 1 hour and 42 minutes into this discussion. And I think it's a good place to stop, but also think it's a good place for us to see where we're at and where we're going. So let's just take a quick look. So remember, you need to read all these handouts. There's your antifungal cheat sheet. So that ends week 3, I'm sorry. Week 3, lecture 1. So lecture 2, I'm going to put start with. It looks like we're going to jump into our antiprotozoals. We'll quickly hit antivirals, and we are done with the anti-infectives. So I'm going to put start with antiprotozoals again. Any of my colleagues at United Regional that are watching this, if you have questions, I love to talk shop. My PA students who are watching this, same thing, love to talk shop. But after that, we're jumping into pain, inflammation, and we're going to be cruising our way through this. So anyway, I hope you'll enjoy the lecture as much as I enjoy giving it and sharing information, but also sharing my experiences with the drug. The ID world is the one thing I can actually say I'm good at. Pharmacies, it's dynamic. Pharmacy is like you all going into medicine. You can't know everything, but can you be good at a few things? So that's kind of where my focus is. is instead of knowing a little bit about a lot, can I know a lot about a little? So that's kind of what I'm going for here. But anyway, appreciate your time, appreciate your attention, and be well.